Okay. Give it about a minute after the hour, Ava.
Yep, that usually works.
Okay, I think we'll start. All right, good morning, everyone. It's a pleasure to introduce our guest speaker this morning for the 2021 Jonathan Jonas Lecture. This lecture is established in memory of Jonathan Jonas, specifically to bring world-class investigators in hematologic malignancies, specifically those interested in non-Hodgkin's lymphoma and Hodgkin's disease, to Washington University to showcase their wares, so to speak. And it's really a great pleasure today to introduce one of the leaders in the field of non-Hodgkin's lymphoma, LaCasce. LaCasce is currently an associate professor of medicine in the Department of Medical Oncology at the Dana-Farber Cancer Institute in Boston. She's a graduate of Bowdoin College. And by the way, Ann, I went to Williams College, and I remember many late night bus rides. I played hockey at Williams to go to Bowdoin. And I remember Bowdoin as being the most hostile hockey rink in the entire world. But Bowdoin's an absolutely beautiful place for any of those in the audience who have never been there. It's spectacular. You want to visit the Longfellow Library when you go there. In any event, Anne went on to do her medical school at Tufts, and then her internship, residency, and chief residency in internal medicine in the Brigham and Women's Hospital at Harvard Medical School. She stayed on at the Dana-Farber as a fellow in hematology oncology, and then she's risen in the ranks through and assumes many leadership positions at Dana-Farber, including she co-directs the Center for Adolescent and Young Adult Oncology. She's a program director for the fellowship and actually director for the advanced fellowship in hematologic malignancies. She's a driving force behind many societies that we all participate in. And she's well known to all as a world-class clinical investigator in hematologic malignancies and non-Hodgkin's lymphomas, but also as a mentor and as a real driving force for the development and career development of fellows at Dana-Farber. I had the opportunity to review Dana-Farber's Department of Medical Oncology recently, and the one thing that stuck in my mind was her commitment to education and mentoring. So a friend to many, a mentor to many, and it's just a delight to introduce Anne this morning as the 2021 Jonas Lecturer. Her title is Improving Outcomes in Diffuse Large B-Cell Lymphomas. Anne, welcome to Washington University.
Oh, thank you so much. What a kind introduction. And it's really just such an honor to be here to give the Jonas Lecture and to be, I wish I were in person at WashU. So here are my disclosures. So these are the learning objectives. We're going to talk about diffuse large B-cell lymphoma today, both the current management for previously untreated patients, as well as therapeutic options in the relapse and refractory setting, including recently approved novel agents. Here is my outline. We'll talk a little bit of background about epidemiology of the disease and risk stratification, review where are we now in terms of initial therapy and relapsed and refractory options, And then at the end of the talk, focus on where we're going, because I think there's some really exciting new things coming down the line in lymphoma, including novel genomic classifiers, newer agents, and how we can potentially identify early treatment failure. So as many of you probably know, non-Hodgkin lymphoma is a relatively common malignancy. It's the 7th most common cancer seen in the US, with about 78,000 new cases a year, 20,000 deaths per year. It is predominantly a disease of aging, and the median age is in the mid-60s. And improvements in survival have really been quite dramatic over the recent past. And now the 5-year survival overall for non-Hodgkin lymphoma is approaching 75%. So within non-Hodgkin lymphoma, I think this is often very confusing for house staff and early fellows because there are really so many different subtypes of non-Hodgkin lymphoma classified according to the WHO or World Health Organization classification schema. And there are more than 50 different subtypes depending upon how narrowly you subclassify things. But today we're going to focus on diffuse large B-cell lymphoma, which is the most common subtype and accounts for about a third of cases in adults. And when we think about aggressive non-Hodgkin lymphoma, diffuse large B-cell lymphoma not otherwise specified is the most common subtype we see. It's the vast majority of cases. And what I'm going to talk about today really applies to DLBCL NOS. There are 2 other subtypes I think worth mentioning. One is what is called high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. This is a so-called double or triple hit lymphomas. Fortunately, these represent fewer than 10% of cases and do have more aggressive behavior, and the treatment algorithms, at least up front, are a little bit different. There's also an entity called high-grade B-cell lymphoma not otherwise specified. This was recently renamed, and this shares morphologic features between diffuse large B-cell lymphoma and Burkitt, and is even more rare than double or triple hit lymphoma. The optimal therapy is not well understood. But again, we'll be focusing over here on the more common DLBCL NOS. So I thought I'd present a case. So this is a patient of mine I initially met in 2016. She presented with sort of respiratory symptoms and vague myalgias, and then noted some lymphadenopathy in the neck, which seemed to be progressing relatively rapidly. She saw her primary care physician, who obtained a CT scan of the neck, and she had bilateral nodes measuring up to 3.3 centimeters. She had a biopsy, a surgical biopsy, which revealed diffuse large B-cell lymphoma, non-germinal center subtype. We'll talk about what that means. And she did not have overexpression of MYC or BCL2, so she was a non-double protein expressor. The Ki-67 fraction was moderate at 50 to 60%. She had FISH, which did not reveal a rearrangement of the MYC gene. She then underwent a PET scan, which revealed high burden disease above and below the diaphragm, largest node measuring about 4.6 centimeters, high SUVs well above 25. She also had disease within the spleen and bony sites of involvement in the pelvis. At the time of presentation, she had no constitutional symptoms, and her LDH was high at 463. So the evolution of chemotherapy and diffuse large B-cell lymphoma is very interesting from a historic perspective. In the late 60s and early 70s, CHOP chemotherapy, which is a 4-drug combination consisting of cyclophosphamide, doxorubicin, vincristine, and prednisone, as you probably all know. This regimen was put together with the idea of combining non-cross resistant chemotherapy agents, modeling after successes in acute lymphoblastic leukemia. And this really remained the standard treatment for about a decade. And then in the 80s, 2nd and 3rd generation regimens were put together in the thought that more had to be better. So this included adding other chemotherapy drugs and intensifying the regimen. And in phase 2 studies, which were conducted at multiple different centers, these studies looked very favorable. However, when the appropriate randomized study was then done in the late 90s, CHOP was just as good as these more comprehensive regimens, but was associated with less toxicity. So where are we now? the therapy that we use, R-CHOP chemotherapy, was really established in the early 2000s. The monoclonal antibody rituximab, which targets CD20, which is expressed on the vast majority of mature B-cell lymphomas, works in multiple different ways, including antibody-dependent cellular cytotoxicity, complement-mediated cell destruction, and then it also appears to have some direct effects on tumor cells causing apoptosis. So in this study, first was published from France in patients over 60 comparing CHOP to Rituxan plus CHOP, and you can see there is a significant benefit in overall survival. The MINT study then looked at patients who were under 60 with low-risk disease, and again, the addition of rituximab to chemotherapy was associated with significant improvements in overall survival. So then along came a real focus on trying to understand how we could identify patients who were going to do well and those who were going to do poorly. We know overall with our CHOP chemotherapy, about 65% of patients will be long-term disease-free with R-CHOP. And when you look under the microscope morphologically, and even looking at things like the Ki-67 fraction or other pathologic correlates, those don't really necessarily tell you how someone's going to do. So we have a very robust clinical prognostic indicator, the International Prognostic Index, which incorporates risk factors including age over 60, advanced stage disease, involvement of more than one extranodal site, performance status, and LDH. And this clinical prognostic indicator scale has really been fallen out in numerous, almost all clinical trials. It always remains prognostic. And with the addition of rituximab, we have the revised International Prognostic Index, and you can see that the number of risk factors correlates with disease-free and overall survival. So then along came gene expression profiling, and this was a technology where individual tumors were assessed for their expression of different genes, and they cluster into various subtypes. So this illustrates the molecular heterogeneity of diffuse large B-cell lymphoma, dividing the disease into a germinal center subtype, an activated B-cell subtype. So this corresponds to a more mature B-cell after it's gone through the germinal center. And then there is a type 3, which didn't fall into either of those groups. Well, doing gene expression profiling in real time is not feasible. We need to get a diagnosis for patients. It's also expensive. So there was an immunohistochemical stain that was developed by pathologists to recapitulate this classification schema using CD10, BCL6, and MUM1. And using these, you can identify whether someone has germinal center or non-germinal center. And we know that patients treated with R-CHOP who are germinal center subtype have better outcomes. And this is about somewhere 85, maybe 90% accurate in terms of how it corresponds to gene expression profiling. So now that we have CHOP and we're beginning to understand the heterogeneity of the disease, is there any way that we can use this information to incorporate novel agents to improve upon our CHOP? And then the other question is, with the addition of rituximab, does it again make sense to go back and look, could an intensified regimen be more effective in this setting? So there were a series of studies looking at changes to R-CHOP, either giving it every 14 days compared to every 21, or intensifying the schedule and dosing of rituximab. And those showed no benefit compared to R-CHOP 21 given every 3 weeks. Obinutuzumab is a glycoengineered anti-CD20 antibody, which is more potent in CLL and some maybe in indolent non-Hodgkin lymphoma. But when that was combined with CHOP and compared to R-CHOP, again, we didn't see any improvement in progression-free survival. So there is a regimen called dose-adjusted EPOCH-R, which was developed by the National Cancer Institute, and this is a little bit different than R-CHOP. It adds etoposide, and the etoposide, doxorubicin and vincristine, are given as a continuous infusion over 4 days. And the other part of this regimen is that the doses of chemotherapy are escalated to drive patients to become neutropenic in hopes of overcoming differences in intrapatient metabolism of chemotherapy drugs. And in this phase 2 study from the NCI, you can see that the event-free survival here looks quite favorable, 80% compared to what historical controls would be more like 65, 60%, something like that. However, you can see a theme here when this was compared in a randomized study in the US intergroup led by the Alliance and published. The first author is your own Nancy Bartlett. You can see that, again, no difference in progression-free survival. Part of this study was designed to also look at the molecular subtypes to ask the question, does the activated B cell subtype do better with our EPOC, or can we identify a subgroup who may benefit? And that analysis is still ongoing. When you look at the forest plot from this randomized study looking at subgroups, in the middle here, you can see patients according to the International Prognostic Index. And you can see here, there is a very strong trend in the high-risk patients towards a benefit to dose-adjusted R-EPOC. But you can see that the number of patients with high-risk disease is quite low. And this is, again, another theme in clinical trials in diffuse large B-cell lymphoma. The problem is that when patients are highly symptomatic with high-burden disease and present to the inpatient setting or have a short, what we call diagnosis to treatment time, those patients are often unable logistically to be enrolled on clinical trials. And it may be this group of patients who really may derive the highest benefit from intensified regimens. The only chemotherapy regimen that has been shown to be superior in randomized studies to R-CHOP is this French regimen called RACVBP. V is Vindicine and B is bleomycin. It also includes a consolidation phase with ifosfamide and methotrexate. So it's really quite an aggressive regimen. And we obviously don't have Vindicine in the US available. And in this study in younger patients, it was a select group of patients under 60 with one of these risk factors. There was an overall survival benefit with the very intensive regimen, but this benefit was limited only to those patients who were non-germinal center subtype. What about maintenance or consolidation? These strategies have been investigated in randomized trials. Rituximab was given as maintenance after R-CHOP chemotherapy without improvement in failure-free or overall survival. Lenalidomide was studied in older patients after R-CHOP in responding patients as maintenance, and there was an improvement in progression-free, but not overall survival. Autologous stem cell transplant, high-dose chemotherapy with stem cell rescue is our standard therapy in chemotherapy-sensitive relapse and refractory patients. There have been a number of studies looking at incorporating this as consolidation after upfront therapy. And in there was a large US intergroup study which showed no difference in overall survival. An unplanned subset analysis of high-risk patients suggested a possible benefit. The Germans also did a study of R-CHOEP, so adding etoposide to R-CHOP, which is their standard in younger patients, and comparing it to a very, very aggressive chemotherapy regimen with multiple stem cell reinfusions. And again, there was absolutely no benefit. So we know that intensified chemotherapy is probably not a good option in DLBCL. So going back to our molecular understanding of the heterogeneity of diffuse large B-cell lymphoma, in the activated B-cell subset in particular, there are multiple signaling pathways that have been shown to be very important in the pathogenesis of the disease, including signaling through the B-cell receptor and signaling through MyD88. And this has led to the identification of a number of potential drugs to study, including ibrutinib, the inhibitor of BTK. You can see here many of these, both of these actually converge on the NF-kappa B pathway, and we have bortezomib as an inhibitor of that pathway. Lenalidomide also is a rational target in ABC, diffuse large B-cell lymphoma. So that understanding led to a series of studies that have been done comparing R-CHOP to R-CHOP plus a novel drug limited to the non-GCB subset, which biologically where the rationale sits. And as you can see, there have been, here's examples of 3 randomized studies. The first with bortezomib plus R-CHOP, again, no difference. Lenalidomide plus R-CHOP, this was very recently published in the JCO. No benefit, and ibrutinib in the Phoenix trial here, these curves are lying on top of each other. So the question then becomes, why did these studies fail? We have this rationale, and these particularly ibrutinib and lenalidomide may have some activity, single agent in the relapse and refractory setting, though modest. And again, it may go back in part to this notion that the highest risk patients are not enrolling on clinical trials, and perhaps they're the ones who might derive benefit. And when you add drugs to R-CHOP, particularly on older patients, there may be myelosuppression, which could impair the ability to give full dose R-CHOP. And that was seen in this ibrutinib study. Older patients did not get full dose R-CHOP, or more often had dose reductions. And it appeared in pre-planned subset analysis that the younger patients may benefit from ibrutinib plus R-CHOP, but obviously that would need to be tested in the appropriate study. And what about elderly patients? I think we see a lot of, as the US population is aging, we see a lot of patients who are in their 70s, 80s, and higher. And what do we do with those patients? This is a phase 2 study that was done in patients over 80 with mini R-CHOP, which is basically half dose R-CHOP. And you can see the overall survival is reasonable. So this is often what we'll do in those oldest patients. There was recently a very interesting and comprehensive geriatric analysis. It was called a simplified geriatric analysis to apply to patients being treated for diffuse large B-cell lymphoma over 80. And you can see one of the problems here, I think, with these scales is that they're a little bit hard to apply in the clinic without having additional time and resources to do them. But they took these patients and looked at their activities of daily living, their instrumental activities of daily living, the CRSG score, which is a cumulative illness rating score for geriatrics, and then looked at age, and then classified patients as either fit, unfit, or frail. When that was combined with the International Prognostic Index, as well as hemoglobin, which fell out in multivariable analyses, they were able to come up with a risk score for elderly patients. And over here, you can see the training and the validation cohorts for overall survival. And you can see for those patients who really have highest risk disease that combination chemotherapy is probably not an appropriate option, and hopefully we'll have better options for these patients moving forward. But I think this is worth thinking about as you see elderly patients coming into the clinic. So for the initial therapy of diffuse large B-cell lymphoma NOS, in summary, R-CHOP still remains the standard of care. The germinal center subtype is associated with better outcomes. The one exception to that is patients who have double hit lymphoma, and those are usually germinal center subtype, and they do less well. There's no evidence of adding consolidation or maintenance, and adding novel agents to R-CHOP to date has not improved outcomes. So going back to my patient, she was in her early-ish 70s when she was treated with R-CHOP and really tolerated it quite well, achieved a complete remission. Unfortunately, about 6 months later, she developed recurrent mesenteric adenopathy and an abdominal soft tissue mass. Biopsy showed recurrent diffuse large B-cell lymphoma with similar immunophenotype. The Ki-67 fraction this time was now up to 90%, and she had, relatively low burden disease. So for our patients who are younger, and the definition of younger really depends on who you ask, we tend to consider autologous stem cell transplantation in patients 70 for sure, sometimes up to 75 depending on comorbidities. And the reason that we consider using stem cell transplantation is based on the PARMA study, which was published in the mid-90s. And this took patients with relapsed or primary refractory aggressive lymphoma. They received DHAP containing cisplatin and cytarabine. Patients who responded were then randomized to additional chemo versus transplant. And you can see there's a significant benefit in event-free and overall survival. More recent data has suggested that achieving a PET complete remission prior to transplant is predicts for favorable outcome. There's some controversy about partial remission patients, and I think for those who have a very good partial remission, we would consider doing stem cell transplant. But for those patients who are chemotherapy refractory, the outcomes are really quite poor, though improving. And that's why I said I'm being was dismal. Hopefully, I'll convince you that we have better options now. And with response rates of third-line chemotherapy being about 30%, with really very few patients having durable remissions. So there have been a number of approved agents since 2017, which we'll go through, including polatuzumab vedotin, tafasitamab, lenalidomide, selinexor, and CAR T-cell therapy. So polatuzumab is an anti-CD79B antibody drug conjugate to MMAE, which is a microtubule inhibitor. CD79B is expressed on the surface of the vast majority of B-cell non-Hodgkin lymphomas. And in this phase 1 study, you can see in these waterfall plots, it was really quite an active drug, both in indolent and aggressive lymphoma. Some of these patients also received rituximab. In terms of toxicity, not surprisingly, given the mechanism of action, peripheral sensory neuropathy was common, but typically low grade. And we see this with other antibody drug conjugates with MMAE, and there was some neutropenia. So this led to a randomized phase 2 study of polatuzumab bendamustine rituxan versus bendamustine rituxan alone in patients with relapsed and refractory large cell lymphoma. And you can see here the number of prior lines of therapy was about 2. This was an active regimen with an overall response rate of nearly 63%, CR rate of 50%. And you can see here there was both a progression-free and overall survival benefit. The median progression-free survival is about a year, though there are some patients kind of out here on the tail, though the numbers are very small. I would point out that BR, bendamustine rituxan, is really not a good regimen for aggressive lymphoma and not something that we would have ever chosen to treat patients with. But that being said, this is a very active regimen and is now approved in patients with relapsed and refractory disease. So selinexor is an interesting drug with a novel mechanism of action, which has been approved first in myeloma and now in patients with relapsed or refractory large cell lymphoma. It is an inhibitor of XPO1 or exportin. This protein sends both tumor suppressors out of the nucleus, transports them out, and also sends mRNA for oncoproteins out into the cytosol where they can be translated into oncoproteins. And by blocking this, the idea is theoretically to keep all these things in the nucleus, and there's good preclinical data to support the rationale of using this in B-cell lymphomas. So this drug is given 60 milligrams orally twice a week. So that tells you something about the tolerability of this drug. It really couldn't be given any more often because patients just didn't tolerate it due to GI toxicity. The other thing about this study, which was a phase 2 study of, large phase 2 study of nearly 130 patients, most of whom had had 2 prior lines of therapy, it was designed really to enroll less aggressive patients. So patients who are refractory to their most recent chemotherapy regimen, and that is the majority of our patients with aggressive lymphoma, had to wait 98 days before they can enroll in this study. If they'd responded to their last therapy, they could enroll after 60 days. So here we're really cherry picking patients who seem to have more indolent diffuse large B-cell lymphoma. And the activity was really relatively modest. Overall response rate 28%, complete remission rate 12%. And when you look at the toxicity, although we really don't see a lot of grade 3 and 4 toxicity, the rates of grade 1 and 2 nausea, weight loss, vomiting are high, 50% nausea. And although grade 1 to 2 isn't horrendous, living with that chronically, I think, is really problematic for patients. And, in my mind, this drug has a relatively limited applicability to our patients, maybe in an older patient who had relatively slow growing disease and was not a candidate for more aggressive things because the response rate really isn't great. Well, what about PD-1 inhibitors? This has been a strategy that has been very effective in many other types of cancers, and particularly in Hodgkin lymphoma. So this was tested in diffuse large B-cell lymphoma, and you can see in this phase 2 study the overall response rate in patients who'd had prior auto was 10% and auto ineligible only 3%. So this is really not a good strategy, though there are some possible exceptions sort of driven by biology. So primary mediastinal large B-cell lymphoma, which actually shares features with classic Hodgkin lymphoma, responds very well. Leading to a drug approval of checkpoint inhibitors in that disease. EBV-driven diffuse large B-cell lymphoma and a rare entity called T-cell histiocyte-rich large B-cell lymphoma both appear to have some responses to checkpoint inhibitors, and studies are ongoing. So tafasitamab is a new drug on the scene. This is an anti-CD19 engineered antibody, which has enhanced both NK cell destruction as well as engages macrophages. In preclinical data, it was combined with lenalidomide, which is thought to enhance NK cell activity, and so it showed synergy. So this combination was tested in patients with relapse and refractory large cell lymphoma in a phase 2 study. The tafasitamab is given weekly for 3 weeks and then every other week until progression. Lenalidomide 25 milligrams, so a high dose, full dose for 12 cycles. And this patient population, the majority of patients had only had one prior regimen. And again, not a super high risk population of patients, with LDH elevated in about half of patients. The activity of this regimen is quite favorable, with 60% overall response rate, complete remission rate of 43%. About 60% of patients were able to receive a full year of therapy, either from toxicity or having progression. But nearly half of patients required dose reduction of the lenalidomide, which is really, I think, just too high a dose to consider in this patient population. And about a quarter of patients had to come off the lenalidomide completely. So the median progression-free survival is similar to polatuzumab-based therapy at about a year. But when you look at the patients who had a complete remission, these do seem to be fairly durable, though the follow-up is still relatively short. So more to come with this regimen, and it is now approved in transplant ineligible patients with relapsed large cell lymphoma. So we can't do a talk on DLBCL without talking about CAR T cells. This has really been a game changer in the field. So these are chimeragen antigen receptor T cells. The approved agents we have right now target CD19. And here's the structure. There's a co-stimulatory and a T cell activation domain. Patients undergo pheresis of their T cells. The cells are then manufactured and transduced to express the receptor. Patients then get lymphodepleting chemotherapy to prevent rejection of the incoming cells, and then the cells are infused to patients. So we now have 3 approved agents in diffuse large B-cell lymphoma or large B-cell lymphoma. These are also used in primary mediastinal and transformed follicular lymphoma. And these include axicabtagene ciloleucel, tisagenuleucel, and lysocabtagene. They're really quite difficult to pronounce, but we call them axicel, tisacel, and lysocel. Axicel was the first approved, and its co-stimulatory domain is CD28. The other 2 have 4-1BB. When you collect T cells for axicel and tisacel, they're all T cells, where lysocabtagene miraleucel, which was just recently approved, has a 1-to-1 CD4 to CD8 ratio. The complete remission rates in these studies were about 50%, and these were highly refractory, really very completely different than the prior 3 studies I showed you. These were very sick patients in general. And the progression-free survival at 2 years, which we hope may represent durable remissions, about 40% in axicel. The follow-up for the lysocel study is a little shorter, so about 44%. And there's a recent letter on the tisacel long-term follow-up, a little bit lower at 30%. So the major toxicities associated with this, I'm sure as you all know, if you care for inpatients, are cytokine release syndrome and neurotoxicity. And the axicel product is associated with higher, particularly neurotoxicity. And this is not well understood, but thought possibly to be related to the very rapid expansion of these cells when they are infused into patients a little bit more quickly than the 4-1BB. I would point out here, it looks like the grade 3 CRS here is higher, but a different grading scale was used here. And this is really quite similar to the others. So when we think about CAR T cell toxicity, cytokine release syndrome is manifested by fevers and flu-like symptoms, but also organ dysfunction and hypotension in more severe situations. And you can see here the pathogenesis. This was a nice review article recently published, is cytokine mediated from the CAR T cells and surrounding macrophages, and IL-6 appears to be really a major player in this. And that's why the therapy is typically tocilizumab, which is an antagonist to the IL-6 receptor. We do also give steroids in patients who have severe CRS or in patients who have very early fevers and CRS. The neurotoxicity or ICANS immune cell associated neurotoxicity syndrome is the thing that we really worry about in CAR T cell therapy, because this has rarely been associated with fatal outcomes and has a very broad spectrum of manifestations, everything from mildly delirious to aphasia to seizures to complete, I've seen patients who've been completely obtunded. The pathogenesis here is less well understood and probably relates to having disruption of the blood-brain barrier with CAR T cells elaborating again a number of different cytokines. There may also be contribution by the local cells in the brain, and IL-1 appears to be a significant contributor, and there are now ongoing studies incorporating, looking at anakinra, the IL-1 antagonist, to see if this will be helpful. Currently, the mainstay of therapy is using steroids. These are generally given when patients have early grade 2 neurotoxicity, and then dosed according to what the clinical status is. So my patient received 2 cycles of rice. She had some residual disease in the abdominal wall, and at this point she was in her sort of mid-70s. And I really didn't think her response was adequate enough to take her to stem cell transplant. So she actually went to CAR T cells and did very well. We know that patients who have high burden disease seem to have more CRS and maybe more neurotoxicity. She had no neurotoxicity and achieved a complete remission. So we thought we were doing really well, very excited by how she had done. And then about a year later, she returned for follow-up and was found to have biopsy-proven recurrence. She was treated on a bispecific antibody trial, I'll talk about that in a moment, and had some mild neurotoxicity in that setting, and achieved a partial remission, but still had this residual groin node, and then progressed in that site locally, so we gave her radiotherapy. However, very soon thereafter, she presented with really high burden disease. She had this huge mass in her leg. You can see her leg is really quite swollen here, and a lot of abdominal disease. And I actually talked to her about, this was just after polatuzumab had been approved. We talked about hospice versus giving this a try, and we just decided to give it a try. Her counts were low after CAR T, which often happens. So we gave her polatuzumab and rituximab, and she had a complete remission, just got a holiday card from her. She is more than 1 year out, really quite a remarkable story. So a good ending, and hopefully she'll continue to do well. So now the question is, where are we going? And there's been a lot of advance over the past 5 to 10 years, moving beyond cell of origin to try to better understand the pathogenesis and biology of diffuse large B-cell lymphoma. So there's been work done both at Dana-Farber by Margaret Shipp and colleagues here, and by the group at the National Cancer Institute led by Lou Stout. And you can see here, by looking at not only moving beyond gene expression profiling and looking at recurrent mutations, structural variations, and copy number alterations, diffuse large B-cell lymphoma can be segregated into these 5 clusters in Margaret's work. And then from the Lou Stout's work, there are about 7 clusters. And you can see, previously we had activated B-cell subtype, end of story. And now you can see there are at least 4 subtypes that fall under that. So how do we put all this data together? And I would just point your attention to this really great review article that just came out in the New England Journal and sort of saved the day. I was trying to make my own table, trying to put some of this information together. And I'll tell you, my table looked nothing like this beautiful table. So starting at the top, if you look at the cell of origin, germinal center, activated B cell, unclassifiable, both the LymphGen from the NCI and the DLBCL clusters kind of align here relatively well under these subgroups. And then let's look at this cluster. So cluster 3, diffuse large B-cell lymphoma, EZB in the LymphGen, and this has genetic hallmarks, including alterations in BCL2 and EZH2, leading to deregulation of pathways, including epigenetic pathways, PI3 kinase signaling, immune cell interactions. And in general, this group tends to have a favorable prognosis. Though if you have a double or triple hit lymphoma, that is a poor prognosis. And there are a lot of similarities with follicular lymphoma from a genetic standpoint. And if you look at, on the other end of the spectrum, activated B-cell MCD subtype or cluster 5, these are enriched for MYD88 and CD79 alterations. And we see alterations in signaling through the B-cell receptor pathway and NF-kappa B. This is a group that does quite poorly and interestingly has a predilection to involve the central nervous system or the testicular lymphoma falls into this group. And also interestingly, this has genetic similarities with lymphoplasmacytic lymphoma, which, as you know, is associated with MYD88 mutations. So the question now is, can we improve on R-CHOP with some of these more novel agents or using biology to help us? And the Polarics study was a study that was recently completed looking at, excuse me, my phone keeps ringing, looking at R-CHOP compared to R-CHOP plus polatuzumab. And this, we're hoping, may represent the first improvement over R-CHOP since 2002. So more to come on this. The first MIND study is looking at incorporating tafasitamab and lenalidomide. And then there is also a study adding selinexor to R-CHOP. The bispecific antibodies are a really interesting new approach to immunotherapy. So these are basically off-the-shelf treatments, so we can make immunotherapy without needing to freeze patients' T cells. These are full-length humanized antibodies. In the past, and still in ALL, the BiTEs are used, and fortunately, the pharmacokinetics of a full antibody are actually much better, so you can give bolus therapy or even sub-Q therapy in the case of epcoritamab. So these target CD20 and CD3, so basically you bring the T cell to the B cell and hopefully induce cell killing. And in the recent ASH meeting in December, we saw data, early phase data for 4 of these bispecific antibodies, mosunetuzumab, glofitamab, odronextamab, and epcoritamab. And you can see the overall response rates are looking interesting. And again, these are refractory patients. The epcoritamab looks very interesting. We'll need to see more data. And there are CR rates associated with these molecules. What about making better CAR T cells? So this is the AutoCell data. This was a CAR T cell construct that targets not only CD19, but also CD22 to hopefully overcome any resistance to with loss of CD19 or other mechanisms there. And in a phase 1 study, again presented at ASH this year, the overall response rate was 65%, and this was the dose escalation study with a CR rate of about 50%. So, more to come on this. And then the other approach, which I think is really interesting, is thinking about using healthy donor T cells. So our patients whose T cells we freeze for CAR T, have typically had significant prior chemotherapy, which can affect T cells. And here we are transducing these, maybe not robust T cells. So using this approach, you can get donor healthy T cells, and then they're engineered to not only express the CAR on the surface, but also to take off the T cell receptor and CD52, so that we reduce the risk of graft versus host disease from these incoming cells. Patients also get intensified lymphodepletion here, and then get infused these cells. And I will say we're participating in a study with these allo CARs, and the responses so far are looking very, very interesting. Obviously, we'll need more data to see, and the tolerability is looking good. So we have CAR T cell therapy. It's a very effective strategy or quite an effective strategy in the relapse and refractory setting. And then the question becomes, can we incorporate that earlier in the course of therapy to improve outcomes? So there have been 3 randomized studies comparing CAR T cell versus salvage chemotherapy followed by autologous transplant in patients with primary refractory or early relapse disease. We're hoping those will read out soon. In addition, there was a study at ASH again this year looking at, can we identify patients who are not responding well to R-CHOP and treat them early with CAR T? And that strategy, we need a lot more information about that, but was an interesting approach. So is there any way we can identify? I think part of the problem with that sort of approach is, how do we know that someone is really an appropriate candidate for significant intensification? Are they going to fail R-CHOP? And this is correlative data from the Alliance study comparing R-CHOP and R-EPOCH, and using Deauville scores. This is our standard way of interpreting PET scans, looking at the avidity on the standard uptake units, and comparing it to background. We can look and see after 2 cycles of chemotherapy, whether you had a high or a low Deauville score really didn't seem to correlate with progression-free or overall survival. And this is different than, say, in Hodgkin lymphoma, where PET can help us risk stratify better than this. So what if you look at other ways of trying to interpret the PET? So looking at the change in SUV and using a cutoff, here the cutoff of greater than or equal to 66% reduction in uptake compared to less. And you can see this helps a bit here. And this was a trend to progression-free survival benefit. And there was an overall survival benefit in those patients who had better responses. So more to come. There are some other novel ways of looking at PET data or other imaging that may ultimately be helpful. And then the other emerging way of looking at monitoring response is using circulating tumor DNA. This has been done in a lot of other types of cancers. And the idea being that the tumor cells shed some DNA out into the peripheral blood, and the genetics and mutations in these bits of DNA reflect the underlying disease. So currently we have clonotype is approved, and this looks for the VDJ gene rearrangements. You have to look at the baseline tumor specimen to identify those, and then you can track it in the blood looking at circulating tumor DNA. There is another technology from Stanford called CAP-seq, and now there's a next iteration of that looks at multiple different commonly mutated genes in the peripheral blood, and this is looking perhaps even a better predictor of outcome. So the idea here is, when you first meet a patient, you can measure how much ctDNA is present, and this may actually correlate in and of itself with prognosis. And then as you treat patients, these levels come down and hopefully go away completely. But then you can see early, the hope is that we could pick up early recurrences using this, because we know that using imaging, surveillance imaging in diffuse large B-cell lymphoma has not been a good strategy for improving outcomes. So more to come on this. And this is one study that was published from the group at Stanford, looking at if patients had a major molecular response, defined as more than a 2.5 log decrease in circulating tumor DNA after starting R-CHOP chemotherapy, this was associated with significant improvement in event-free survival. So in summary, where are we now? We're stuck with R-CHOP, but hopefully that's going to change soon. For patients who have chemotherapy sensitive relapse, auto transplant is the standard of care and results in long-term disease control in about 45% of patients. CAR T-cell therapy is associated with durable remissions. We think in patients, about 40% of patients who are chemotherapy refractory. And we have a number of new novel agents already approved over the past couple of years, including polatuzumab in combination with bendamustine plus rituximab, tafasitamab, and lenalidomide, and selinexor. So where are we going? I think the hope would be that as we meet a new patient with DLBCL, we're able to really analyze that patient's individual tumor to really try to rationally incorporate drugs that might be of benefit, looking at the clusters or the LymphGen profiles there and incorporating drugs that really might make sense, a personalized medicine approach. In combination perhaps with immunotherapy, so targeting these widely expressed cell surface markers like CD19 and CD20. CAR T-cell therapy has been really very promising success already, and these new constructs may be significantly better, and perhaps combining those with immunotherapy or targeted agents may be a good strategy. And then we have all these bispecific antibodies that hopefully will lead to easier administration of immunotherapy, and we'll need to compare those to CAR T cells. And then a lot of work on identifying early resistance and surveillance for relapse disease using novel imaging techniques and circulating tumor DNA. And I just want to highlight, I think we're still at a point where it's really important for us to get tissue on patients who have relapsed or refractory, or obviously up front, so that we can do all these more comprehensive genomic assessments and collecting blood for looking at cell-free DNA. So with that, I'd like to thank my group. Here are all my colleagues, really an amazing group we have lots of translational scientists, lots of young translational scientists in our group, and senior translational scientists. And, we really collaborate together in everything that we do, and it really makes it such an incredible place to work. And then also, again, like to thank Deborah and Stephen Jonas in memory of their son, Jonathan, and give a shout out to Nancy Bartlett, who is just a phenomenal colleague and friend, and has been a mentor to me over the years. So with that, maybe we could take some questions.
Oh, that was terrific, Anne. Thank you very much. So I have a few questions, but there's one question from the audience. Are patients with double hit diffuse large B-cell lymphoma more likely to have a relapse?
Yes, so double hit lymphoma. So again, those are patients who have MYC rearrangements, not overexpression. You have to do FISH analysis to look for a rearrangement. And then in most places that will trigger then looking for BCL2 and or BCL6. If you have 2, then you're a double hit. If you have all 3, you're a triple hit. It's not clear triple hit is any worse than double hit. And the studies suggest that R-CHOP is not adequate for that subset of patients. And we typically treat them with dose-adjusted R-EPOCH. There have not been any randomized studies to really show that this is a better strategy, but it has really become the accepted frontline therapy based on multi-center phase 2 studies. So this is an area where we really need new therapies because they are much more likely to have primary refractory or relapsed disease.
Okay, Nancy Bartlett has a question. She's asking, she says, great job, Anne. Do you think that we are ready to test CAR Ts as first-line therapy? And if so, how do you choose the patients?
Yeah, I think that's a great question. And, I'm not sure that we are ready yet to do that, because we really have to identify those patients who are going to fail R-CHOP. R-CHOP is curative in DLBCL NOS in more than half of patients. And I think the cost and risks associated with CAR T are substantial. So we've got to be really sure that we know that a patient is destined to fail. And I think, using PET alone as a means of then taking a patient off early to go to CAR T, I think is not a good strategy. And I think we really need to validate these CAPS-seq or clonotype or something to help us really select those patients, because at $450,000 a pop, this is not a sustainable a strategy in the most common lymphoma that we see in adults.
Another question, Anne, is the regulation of CD20 in diffuse large B-cell lymphoma understood? Would strategies aimed at preventing CD22 downregulation improve R-CHOP response rates or make Rituxan maintenance more of a viable option?
So that's a good question. We generally don't see loss of CD20 in relapse. When you biopsy patients who have relapsed large cell lymphoma, it is pretty uncommon to see loss of CD20. If you do flow cytometry, sometimes you'll get interference. The Rituxan will still be on board, so it will look like there's loss of CD20, but there really hasn't been. So I don't think that that's really the issue. I think it's, why it doesn't work in maintenance therapy. I think there's for many patients, there's probably not residual disease there, those patients who are cured, and those who are not, are more resistant and need other approaches.
I have a question relating to, just from my leukemia perspective. Tony Latai's work at your center has focused on BH3 domain blockade and priming as an important sensitizing step. And this has been pursued, of course, in primarily successful in elderly AML patients. And I think the result of this work has suggested that perhaps an initial deeper remission rate or remission is maybe predictive of better outcomes. So has anybody tried to incorporate BCL2 or MCL1 inhibitors with standard therapies in the upfront setting for diffuse large B-cell?
Yes, absolutely. So, a number of our patients, particularly the germinal center subtype, will have BCL2 rearrangements. Many of our patients, the activated B-cell subtype, have overexpression of BCL2. So it is a very, appealing target in DLBCL. And there was the Cavalli study that combined venetoclax plus R-CHOP, and that included patients with DLBCL. One of the issues is the toxicity. When you give venetoclax, it is myelosuppressive, and it does interfere with the ability to give full dose R-CHOP. And there is an alliance study ongoing right now looking at adding venetoclax to R-CHOP, randomized to R-CHOP alone in the double protein expressors. I think just in the patients we've seen, and it has been combined with our EPOC, but very toxic, very, very toxic. So it's not 100% clear. I mean, it's so interesting because venetoclax in CLL is a home run. That has just been a game changer and such an active drug. But I'm just not as convinced about how its activity. And, I know Tony really thinks it's this sensitizing to subsequent chemotherapy is a major mechanism there. But, R-CHOP is very DLBCL is very chemosensitive to begin with. So I think we need more information. We'll need these randomized studies to show, is it really a strategy? And I think he's doing a lot of work doing BH3 profiling. There are MCL inhibitors that are coming out to see whether we can, and it may be a patient selection issue. We really have to figure out who are those patients who are going to benefit.
So Anne, one more question that I had, and also David Ressler-Germain, a fellow with us, we're thinking along the same track. So what is your approach to treatment of CNS disease and CNS lymphomas? The recent review from, I guess it's Sales or Sally's or something.
GeoSal, yeah.
Journal, suggested that that IT therapy not be given in those patients.
Yeah. So this is a highly, highly controversial area, and we are really lucky in that we have two neuro-oncologists who focus on CNS lymphoma. So we have a lot of studies going on. And, you know, they feel, and now I think we all have adopted their thoughts, that IT chemo, you know, when you give 12 milligrams of intrathecal methotrexate, it does not penetrate into the brain parenchyma. You're just barely hitting the leptomeninges. And when you give high dose systemic methotrexate and it comes up through the blood-brain barrier, you're getting much better concentration, both in the brain and the leptomeninges. So we almost never give IT chemo. We think it's not a useful strategy. So with primary CNS lymphoma, we tend to initially treat them with methotrexate, high dose methotrexate with Rituxan, Temodar, usually based on the Alliance study, the MTR regimen. And we have been doing a lot of upfront consolidation with autologous stem cell transplantation because we know these patients with chemotherapy alone, the majority, probably 80% plus, are going to relapse. And we really try to avoid brain radiotherapy because it is associated with significant neurocognitive deficits. So I think that patient population we're doing, I think, quite well with by consolidating them up front. The elderly ones a little bit more difficult. We have some studies looking at novel agents. You know, they fall into that MCD group. So ibrutinib, BTK inhibitors, lenalidomide, and immunotherapy are promising in that disease. I think the other really difficult part is what to do about prophylaxis. So we can identify patients who are at high risk for CNS recurrence using that International Prognostic Index plus renal or adrenal involvement. And their risk can be, you know, up to 15%. And we had been giving a lot of high dose systemic methotrexate thinking that we were improving the risk of subsequent recurrence in the brain. And our group just decided, based on, there were a couple of papers at ASH, this has never been studied randomized fashion, but a couple of studies really showing that high dose methotrexate probably doesn't have a huge impact on that risk. And I think this is an area where we really need to do some studies. We need to take that MCD cluster and think about, you know, maybe looking at cell-free DNA in the CSF, or, you know, trying to identify early, do patients have some occult disease there, and really have a better strategy, because I think we've all given a lot of high-dose methotrexate here, and I think we were probably mostly treating ourselves, though the testicular part, the testicular large cell, probably we will continue to do, because that risk is very, very high, more like 20%.
I think we're just running over here, Anne. So I will end it here. Unfortunately, we have a lot of other questions. A lot of people are saying hello to you.
I love your group.
You can look at the chat. So that's really nice. Listen, I want to thank you for a terrific talk and for taking the time to spend an hour with us this morning.
Oh, it's such a pleasure.
Yeah, and I look forward to seeing you in person someday soon, maybe in the next 30 or 40 years.
Yeah, exactly.
And again, thank you for your time. It was a great talk. Thanks.
All right. Take care. Thanks again.
Bye-bye.
Bye.